And so our next presenter is someone who has done a great deal of work at the community level. So I'd like to introduce George Ayala. He is the Executive Director of the Global Forum on MSM and HIV, where he leads the agency's international advocacy, education, community-based research, and capacity-building assistance activities. A clinical psychologist by training, Dr. Ayala has conducted HIV social science and intervention research since 1996. His research has mainly focused on understanding the mechanisms through which social discrimination affects the sexual health of gay men of color in the United States. His most recent work zeroes in on the facilitators and challenges and challenge barriers to HIV-related services among gay men and MSM worldwide. Dr. Ayala.
Good morning. Good morning. I just want to make sure you're still with us. It's a tough spot to be in the speaking order because we're just before break, so I really appreciate you hanging in there with us. So today I want to just kind of end the morning by scoping out again and focusing on what's happening with MSM at the global level as a way to contextualize the conversations that we're having locally. And the local epidemics among MSM are global epidemics, and there's linkages that need to be highlighted and emphasized. And my work actually that I'm going to present today is going to be focused on understanding the predictors of access to HIV services. So I want to spend some of my time focused on sharing with you what the Global Forum on MSM and HIV is doing and is all about. Just spending 1 or 2 minutes talking about HIV among MSM globally, just to give you the context. I want to also talk a little bit about community-based participatory action research as a way to kind of raise questions about community involvement and meaningful engagement of community as we grapple with research, as we grapple with evidence. And there was a lot of evidence presented today. And so I just wanted to kind of use the work that we're doing as the Global Forum on MSM and HIV to raise some questions about how we meaningfully engage community. And then I'm going to zero in on the Gay Men's Health and Rights Study. The Global Forum on MSM and HIV was established in 2006 at the International AIDS Conference in Toronto. It was put together by a small group of very concerned advocates who were working issues related to MSM and HIV internationally and were really frustrated by the relative silence on MSM and HIV issues at the global level. And at that point, we saw relatively little covered at the international AIDS conferences. And we thought it was time for us to call that out. And so we began putting together these pre-conference activities in advance of the International AIDS Conference as a way to raise visibility about our concerns and also as a way to expose, quite frankly, the lies that we were being told about gay men, MSM, and about HIV disease, epidemiologically speaking. Our mission is to work for equitable access to effective HIV prevention care, treatment, and support services for gay men and other MSM, including gay men MSM living with HIV, while promoting their health and human rights worldwide. We are governed by a 21-member international steering group of activists from all parts of the world. Every region of the world is represented. Our work is really guided by 5 main goals, and they include expanded coverage of quality HIV-related services for gay men and MSM, realized promotion and protection of human rights, which is a problem worldwide and certainly a problem in the United States. We don't talk about this in terms of human rights. Here in the United States, it's not popular to do that. We talk about it mostly in terms of sensitivity and discrimination. But I think if we kind of did a deep dive into issues around access to health, we could make an argument for the reframing of discrimination in terms of human rights. The third goal for MSMGF involves increased investment for effective health and rights-based programs, because we know that funding and money is not commensurate with HIV disease burden, and this is true since the very beginning of the AIDS response. Improved knowledge of MSM and HIV through the promotion of research and broad-based information exchange and communication. We need more research. We need research focused on the questions that are important to the communities in question. And we need to do better work, better job at moving information around in a way that is accessible to gay men and MSM, and in a way that engages gay men MSM communities in conversations and deliberations about the meaning of that evidence in the lives, the subjective experiences of men. And then finally, we work very hard to promote engaged, well-prepared MSM advocates linked to each other and to MSM networks at the global, regional, and national levels. From our perspective, it's really important that gay men MSM educate ourselves and begin talking to one another about what's working on the ground, so that when folks are doing service work and doing advocacy work at the local level in Peru, they know what folks in India or in Kenya are doing along the similar lines. And we think that there's great value in those kinds of exchanges. So we accomplished those goals by really zeroing in on advocacy, and for us that means lobbying global decision makers, either at the UN, including UNAIDS and WHO, or with the Global Fund, which is the biggest funder of the AIDS response at the international level. We also lobby donor governments like the United States, which happens to be the biggest contributor to the Global Fund and global financing around the world. And then we, advocate for better public health policies at the country level with health ministries. We provide technical support and education, and there are a couple of targets for the technical support. Certainly MSM and MSM-led organizations are one audience for our technical support, and we work really hard to prepare advocates to be more effective as we advocate with our respective governments, either at the local level or at the country level. MSM advocates and MSM-led organizations are also interested in how best to interpret the latest and greatest evidence and interventions. How do we uptake those from a community perspective? So we provide some technical support in that area. And then the other target for that technical support is health providers and health ministries. And so we try to help health providers and health ministries understand how to deliver services with more sensitivity to the needs of gay men and MSM. We're certainly participating in community-based research, both self-initiated community-based research, which I'm going to talk more about today, and also in partnership with researchers who are based in universities and academic institutions who are interested in really more meaningfully engaging gay men MSM. Communications is a big part of what we do. A large part of how we stay connected to our constituencies and how we connect men globally is through the web and our website. We have a very large online membership of 4,000 men from across over 200 countries, representing over 600 organizations, and it's a big job to keep everyone connected and communicating with one another and engaged on these issues after 30 years. And we spend a lot of time putting gay men and MSM together at conferences, at high-level meetings. We actually support participation of advocates at hearings with the Global Fund or hearings at the UNAIDS, etc. So, and because we foreground human rights, and because we foreground in our work self-determination, we hold that dear to the work that we do, and because we work in coalition, we employ approaches that are community-led, strengths-based, sex-positive, critically reflexive, and action-oriented. Nothing we do is outside of those parameters. And it's important that, that folks be clear about the underlying values that inform the work that we're doing and the parameters within which we do that work. So it's a lead into kind of a quick conversation and a review of the principles of community-based participatory action research. Community involvement is really important, and in community-based participatory action research, if we're doing it well, it's more than just an advisory group of community folks who get together once a month or once a quarter to review how things are going with the protocol. In community-based participatory research approaches, community is involved at all stages of research, from the conceptualization of the research questions to the design of measures and scales and interventions, to the design and of the methods with which we use to collect data, to the analysis and interpretation of data that we secure. So the other thing about community-based participatory action research, mouthful, is that it honors local knowledge. It doesn't think that knowledge is generated outside of a community and then kind of introduced to the community or plopped down on top of a community. It engages in knowledge generation activities in partnership with community, assuming that community comes with its own knowledge and its own ways of generating information. I'm going to move past this really quickly, but you get the idea that community-based participatory action research is really different from how we might think about research. So really quickly, we've heard this repeated as a theme this morning, that gay men, MSM, shoulder a disproportionate HIV disease burden. This is true in all parts of the world. Now that we have good surveillance data, even in places and even in countries where HIV is pretty prevalent in general populations, when surveillance data is available focused on gay men MSM, we see that among gay men, HIV prevalence is much higher than the general population. That's true in Sub-Saharan Africa, it's true in South and Southeast Asia, East Asia, Central and South America, the Caribbean, and Eastern Europe, Central Asia. We know that MSM are 19 times more likely to be HIV positive than general population in low and middle income countries. We also know that only 24% to 55%, based on current studies, of MSM are reached by HIV prevention care services, and that only 37% of MSM report HIV testing in the past 12 months. That's important as we really kind of grapple with trying to understand how to roll out new evidence and new interventions and new technologies as we understand those better. So we've last summer implemented the Gay Men's Health and Rights Survey. The big report on this survey is on our website, which is msmgf.org. This is the cover of the report. The study really aimed to identify factors that hinder and facilitate access to HIV services. We wanted to move beyond individual level predictors of MSM sexual health to include some of the social and structural considerations that Greg flagged for us this morning. And we wanted a survey and a study to reflect MSM voices from around the world. The survey was about 30 minutes in length. It was offered in Chinese, English, French, Georgian, Russian, and Spanish. Gay men from around the world were invited to participate. We advertised the survey through multiple places and through our contacts with community-based organizations around the world, certainly through web banners and through partnerships with websites that partner with gay men. We sent out to our networks, to our listservs, etc. We administered the survey last summer, starting in April, and we conducted several analyses. There's actually a research advisory group that has been convening every 2 weeks over the last, I would say, 2 years, helping us with this. What makes this a good kind of example of community-based research is that we really began this with conversations with gay men and MSM around the world. We were interested in understanding what gay men's concerns were, what was most salient to gay men in relationship to the work that they were doing at the country level, both in HIV, but also in terms of promoting sexual health more broadly. That helped us to identify a preliminary set of major domains. We then went into a process of developing scales inside of those domains, and we did that in many, many ways. We used some of the scales that we used the first time around. We adapted some of those based on feedback we received in those conversations with gay men. We held some additional qualitative interviews, both in focus groups and in individual level. We looked at what other researchers were doing inside of those domains, what other scales researchers had used that were effective, and we borrowed from them. And then we just iteratively developed the survey. We beta tested it online, and then we ran it. And after we ran it, we solicited, and we continue to solicit feedback from gay men who came to us with some really important ideas about how to improve, change, modify the survey moving forward. So we hypothesized a set of barriers. They're listed in this table. I'm not going to go through them very quickly. Homophobia, violence, both related to being MSM or gay man, violence in relationship to living with HIV, and provider stigma. These ended up being reliable scales when we kind of moved them through psychometric testing. We also thought that it was important for us to focus beyond barriers and to take a look or to ask a question about, are there facilitators? Are there things that matter in helping men access services? Outness was one of the things we came up with. Community engagement, connection to gay community, and comfort with a healthcare provider. Also, those scales ended up being quite reliable for us. In addition, we had other types of questions, and in this case I'm focusing on sexual happiness. Sexual happiness is an area of interest and is being studied broadly in Europe and Eastern Europe, Central Asia, and now in the Caribbean. Sigma Group really initiated this area of research, but when was the last time you saw a survey that was interested in knowing how happy gay men were with the sex that they were having? So it's important, from my perspective, to really introduce these kind of questions and to have discussions about interventions in the context of men's lived experiences more broadly, and to recontextualize HIV within sexual health framework. I'm running out of time, so I'm going to move really quickly. The access, the services that we were interested in understanding in terms of access were condoms. So in your community, how accessible or free are free or low cost condoms, lubricants, HIV testing, HIV treatment. We had a pool of participants, more than 6,000 participants total. 71% of those participants completed the survey. In other words, they answered every question to the last question. That's a very high response rate for a survey like this. Had 165 countries represented. Mean age was 35. Most of the men self-identified as gay. 18% said they were living with HIV. In terms of easy access to HIV services, you'll see that we have a lot of work to do in getting men access to basic things: condoms, lubricants, HIV testing, HIV treatment. In this slide, we compared U.S. participants with the rest of the world. And in ways that are predictable, in the U.S., men have more access to condoms than anywhere else in the world, have more access to lubricants than anywhere in the world. And by the way, we don't have conversations about lubricants and why it's important in terms of expectations of condom adherence. And in the U.S., men have more access to HIV testing than everywhere in the world. Where that's not true, at least in this survey, is in HIV treatment. And in HIV treatment, U.S. guys had less access to HIV treatment than anywhere in the world. That's a problem. And then when we looked at the U.S. sample in the survey, we wanted to understand or compare racial ethnic minority participants with everyone else. And you'll see that there's differences across the board, except with HIV treatment. Except for HIV testing and treatment. So in terms of HIV testing and treatment, men are pretty much the same. We have equal access, at least among participants in the survey, to HIV testing and HIV treatment. But in terms of access to condoms and lubricants, there's some disparities. I'm just going to move through these. This tells you the same, it paints the same question, but we ask about predictors of these kinds of services, and we ran them through regression analysis to understand which ones held up. And in the end, some barriers predicted some service access outcome indicators, and some didn't. And so in summary, some predictors of access, like provider stigma, community engagement, connection to gay community, may be specific to HIV service type or subgroup if you're thinking about HIV positive men in comparison to HIV negative men. Homophobia, though, is a significant barrier too, and comfort with providers is a significant facilitator of access across service type for both HIV negative and HIV positive men. I think the implications here is that HIV programs should be comprehensive. They need to be targeted and tailored to the needs of MSM. And it shouldn't assume that the MSM community is monolithic. We should really nuance the approaches and understand predictors of access depending on serostatus and depending on race, ethnicity group, and other ways to characterize the community. We should create enabling policy and service environments to increase access to HIV services, and we certainly have to address homophobia and provider sensitivity as a priority. Just acknowledgements. I also hate these kind of slides because I know I always forget Patrick someone in acknowledging and saying thank you. I do want to call out Coletso Makofani, who is really kind of the chief biostatistician on staff who helped us with these numbers. Thank you very much. Thank you.